In the hours following the injury, the goal is to save the patient's life and preserve function in the wounded limb by applying damage control orthopedics. Depending on the wound's severity, damage control orthopedics will be conservative when the limb can be saved, or radical when emergency amputation is necessary. Damage control orthopedics is based on 3 pillars: controlling bleeding, wound decontamination, and temporarily stabilizing fractures. Overall, surgical management can be summed up by a sequential tactic: 6, 7, 8, 9. Damage control procedures must be implemented within 6 hours. Damage to soft tissues must be treated within 7 days. Bone reconstruction surgery begins around week 8 and strives to restore limb function within about 9 months. A failure at any stage, if infection sets in, especially, is liable to make secondary amputation imperative. The primary goal is to prevent infection, which is an obstacle to all the reconstruction procedures. Surgical decontamination of war wounds is a 3-step process. Removing dead tissue, this is called debridement. Irrigation of contaminated living tissue. Delayed wound closure associated with the administration of preventive wide-range antibiotics followed by targeted antibiotherapy if necessary. With highly contaminated war wounds, debridement must be carried out every 48 to 72 hours until a clean, closable wound is obtained. Ideally, by day 7, it will be possible to close the wound. It may require skin reconstruction if tissue has been lost. Skin graft procedures are selected on the basis of the size and location of skin loss. In the field, fractures are temporarily stabilized using external fixators for long bones and splints for the extremities. The goal is to maintain the alignment of the limb during casualty evacuation in order to limit pain and later complications. Fractures are definitively fixed after the soft tissues have been treated, generally between days 7 and 15. The goal then is to obtain bone union. The choice of a definitive fixation method depends on fracture location and infection risk. Internal osteosynthesis is preferred for the upper limbs and femur. External fixation is often required for the tibia. Bone reconstruction procedures begin around week 8. The point may be to allow for delayed bone union or to reconstruct lost bone. Follow-up surgery is generally necessary to treat osteoarticular sequelae resulting from the high-energy open fractures that occur on the battlefield. These sequelae are pseudoarthrosis, malunion, or joint stiffness. Surgery may also be used to treat neurological sequelae resulting from nerve injury or acute compartmental syndrome, which frequently occur with bullet trauma. Finally, surgery may also repair later complications of amputation stumps, since these complications slow the fitting of prostheses. In civilian practice, these reconstruction principles apply in a similar way to all serious trauma to the limbs, especially injuries from automobile crashes.